Hypothermic cardiac arrests present a unique challenge where conventional resuscitation protocols may not apply. As a patient's temperature declines, processes such as metabolism, drug handling, and the heart's response to defibrillation becomes increasingly sluggish. So in this video, we're going to explore how to adapt our standard ALS, our advanced life support approach, when dealing with a patient who is significantly hypothermic and in cardiac arrest. We're going to reference the latest Resuscitation Council guidelines, RCUK, their 2025 Special Circumstances guidelines. So the key areas of focus: defining and staging accidental hypothermia, adjustments to the arrest algorithm, management of shocks, drugs and CPR, timing for considering ECMO and prognostication. So let's have a look at a definition first. So accidental hypothermia is characterised by an unintentional drop in core body temperature below 35 degrees. RCUK recommend monitoring vital signs for up to a full minute in unconscious hypothermic patients, as all of our bodily functions, including breathing, pulse, responsive levels, slow right down. When feasible, a low reading thermometer should always be used to measure that core body temperature. If unavailable, the guidelines advise employing the Swiss staging system. So if we have a look at the Swiss staging system, we have stage 1. So we've got mild, conscious with shivering approximately 35 to 32 degrees. If we move to stage 2, moderate, we have impaired consciousness, shivering reduced or absent, and they say that that's around 32 to 28 degrees Celsius. Stage 3, severe, we have unconscious but with vital signs present, approximately 28 to 24 degrees. Stage 4 is deep hypothermia. We have no vital signs. This is estimated with a temperature below 24 degrees. Stage 4 is where hypothermic cardiac arrest is categorised. So before initiating CPR, RCUK emphasised the importance of early recognition and triage. Hypothermic patients are at high risk of imminent cardiac arrest, or those already in arrest should be transferred directly to a facility capable of providing extracorporeal life support such as VA-ECMO for active rewarming. Risk factors for imminent arrest and indications for transfer include a heart rate less than 45 beats per minute, systolic blood pressure below 90, ventricular arrhythmias, core temperature below 30 degrees. This should prompt us to consider, is this a potential eCPR or ECMO patient? RCUK advises to begin with the standard ALS algorithm but adapt it for hypothermia. The key modifications will include the approach to CPR, the delivery of shocks, administration of drugs, and duration of our resuscitation efforts. In a normal thermic arrest, continuous high-quality CPR is standard and emphasised. However, in severe hypothermia, this may not always be possible, particularly in austere remote settings. The guidelines state that in hypothermic cardiac arrest, with a core temperature below 28 degrees, if continuous CPR isn't feasible, you may delay CPR or use intermittent CPR while prioritising safe evacuation and definitive rewarming. This does not imply a casual approach to our compressions, rather acknowledges that in certain situations, especially during mountain or water rescues, it may be safer to alternate CPR with transport and team fatigue management, rather than exhausting all of our resources prematurely. Where feasible, consider utilising our mechanical CPR devices such as a Lucas if prolonged transportation or challenging terrain complicates our manual compressions. So defibrillation protocol. So ventricular fibrillation and pulseless ventricular tachycardia are very common in severe hypothermia. We will still administer defibrillation, but the quality and timing of these shocks just needs a slight adjustment. So the recommendations are going to be how we're going to adapt it. For VF and pulseless VT, we deliver up to 3 defibrillation attempts as per standard ALS. If VF persists after 3 shocks and the core temperature remains below 30 degrees, we delay any additional shocks until the patient is rewarmed above that 30 degrees. So initially we're going to treat it like any other shockable arrest. After 3 unsuccessful defibrillations, shocks, with a profoundly cold myocardium, we're going to shift focus to CPR and rewarming, revisiting defibrillation once that temperature has risen. So drug administration. This is where most significant changes occur. In cold patients, metabolism and drug clearance are significantly diminished. Administering adrenaline at typical intervals can lead to harmful accumulation once that patient warms up. So RCUK explicitly recommends withhold adrenaline below 30 degrees as it may accumulate within that circulation. Once the core temperature hits 30 degrees, we're going to administer 1 mg IV adrenaline as per ALS guidelines, unless preparing to start ECPR, which may require a different strategy. For temperatures between 30 and 35 degrees, what we're going to do is we're going to extend the interval between our adrenaline doses. So rather than the 3 to 5 minutes, we're going to have 6 to 10 minutes. So for amiodarone, they advise we're going to administer the standard 300 mg loading dose for shockable rhythms. However, we're going to delay any further doses until the core temperature exceeds 30 degrees. The trend is clear: normal dosing but with significantly cautious timing and no repeated doses below 30 degrees. So if we have a look at rewarming strategies, in the case of a hypothermic arrested patient, RCUK advocates for veno-arterial ECMO as a preferred rewarming method when available. This technique enables simultaneous oxygenation, circulatory support, and core temperature elevation. If an ECMO or ECPR centre is not reachable within a reasonable time frame, for example 6 hours, then initiate non-extracorporeal rewarming as vigorously as local resources allow. This could include things like warmed IV fluids, active external rewarming, warm humidified oxygen when available. But the key takeaway is that resuscitation for hypothermic cardiac arrest is often extended and should continue while active rewarming is underway, unless there's clear signs that indicate that efforts are futile or unsafe. So if we say determining when to stop, historically we've used the phrase "no one is dead until they're warm and dead." So RCUK adds the nuance by suggesting the use of the HOPE score, the hypothermia outcome prediction after extracorporeal life support score, to inform in-hospital prognostication following prolonged hypothermic arrest. They recommend base prognostication of successful rewarming on the HOPE score instead of relying solely on intuition. Consider this in light of an overall clinical picture, local resources and ECMO availability. Thus, by employing a validated tool, we can better estimate the survival probabilities and facilitate shared decision making. So in summary, in hypothermic cardiac arrest, we should carefully check for signs of life up to a minute, measuring the core temperature where feasible. Stage the hypothermia and consider immediate transfer to an ECMO or ECPR centre in severe cases within that up to 6 hours post-arrest. Begin with the standard ALS algorithm, however, accept that intermittent CPR may be necessary, below 28 degrees if continuous compressions are impractical. Administer up to 3 shocks for VF or pulseless VT, then postpone further defibrillation until the core temperature exceeds 30 degrees. Withhold adrenaline below that 30 degree mark, resuming it at extended intervals past 30 degrees as that patient warms up. Provide a 300 mg amiodarone loading dose for shockable rhythms, but delay additional doses until that temperature surpasses 30 degrees. Prioritise active rewarming, ideally with VA-ECMO when feasible, or utilise non-extracorporeal methods if not. Utilise that HOPE score in hospital settings to help guide decision making on the continuation or cessation of prolonged resuscitation. The overarching theme is straightforward. We still implement our ALS, but we slow down our drug administration. We're going to limit shocks in extreme cold conditions and commit to lengthy, rewarming focused resuscitation when the circumstances and resources allow. So thanks for watching. Please make sure you are subscribed to the channel so you get notified of all of our new videos we're going to be releasing over the coming weeks. And also hit the link in the description. It will take you to our website where we've got all sorts of emergency medicine, pre-hospital, education and products.